Good morning, everyone, and thank you for joining this session of the 2022 North Country Leadership Summit, Optimizing Healthcare, Community, Collaboration, and Workforce Resiliency. Just for a few housekeeping items before we get started. Please place any questions you have during the presentation right in the Q&A box or the chat, and we'll ensure that those are addressed during the Q&A portion of the session. We ask that all participants stay muted with their video off for the duration of the presentation. And as a reminder, we will be recording all sessions during the week, and they will all be archived on the North Country Leadership Summit webpage in a couple of weeks for reference after the conference. And with that, I would like to introduce Tom Zucker, Director of Information Technology at Fort Drum Regional Health Planning Organization.
Thanks, Nancy. So good morning to everybody, and welcome to the Telehealth Keynote presentation for this year's North Country Leadership Summit. We're very fortunate to have over 200 participants registered with us today, including 30 speakers and 20 sponsors from all over New York State during this week's conference. So with all of you, this is what makes the conference possible. So thank you for taking the time out of everybody's very busy schedule to be here. So with that, I'd like to introduce our keynote sponsor, Hixney, which is represented by Katie C., Director of Marketing and Communications, and she'll say a few words and introduce our keynote presentation.
Thanks so much, Tom. Thank you to AHI as well for asking Hixney to introduce our keynote speaker this morning. And as Tom said, my name is Katie C. I am the Director of Marketing and Communications at Hixney. Hixney is the nonprofit health information exchange that serves Eastern New York and some areas of Vermont. Our work is centered around ensuring that providers have access to the most comprehensive and up-to-date information on their patients so that they can continue to deliver the most well-informed care possible. And our most recent development, the patient record Snapshot, uses smart technology to put this information at providers' fingertips directly in their EHR. And before I do the introduction, just a small reminder that the Shiny survey is live right now. So if you do receive an invitation to participate, Hixney, as well as the other QEs across the state, do thank you in advance for taking a few minutes to respond. So Dr. Michael Hasselberg is an associate professor of psychiatry, clinical nursing, and data science at the University of Rochester. He's the first chief digital officer at the University of Rochester Medical Center and was recognized by Rock Health as one of the top 50 in digital health leaders, acknowledging his work to improve health equity through technology innovation during the COVID-19 pandemic. His expertise expands health and technology as a Robert Wood Johnson Foundation Clinical Scholar Fellow and advisor to digital health modalities to the New York State Department of Health, the Department of Health and Human Services, and the National Quality Forum. He's here today to speak about the future of healthcare, a future in which the patient's perspective and experiences will drive how care is delivered. So without any more delay, Dr. Hasselberg, welcome.
Thank you so much, Katie. I'm going to pull up my slides here for a second. All right. So I'm honored to be here to speak to this group of leaders of health organizations in New York State. And I think we can all agree that there's no question that the future of healthcare is one that is personalized and it's precise. In the future, the patient's journey will be predicted by the past, and that patient's care will be matched with the right provider at the right time and in the right place. So I asked the question, can machines think? Well, this was a question that was sought to be answered by a company right in our backyard. Does anyone know the name of this company? This company was the International Business Machines Corporation, better known as IBM. It opened its first plant in Endicott, New York, right outside of Binghamton. IBM has been a pioneer in information technology, and it's changed the way enterprises, organizations, and people operate and thrive. In 1914, Thomas Watson Sr. joined the company as general manager. A year later, he was elected as president. Watson was credited for creating a culture of inquisitiveness at IBM. He quickly started the company motto of think. Looking into the future, Watson realized that really the applications of machines and computers were limitless and could actually help people think. He established a culture of encouraging everyone to be a thinker, from the assembly line worker to the engineer to the salesperson to the secretary. With think signs cluttering desks and walls of countless IBM offices, IBM sought to do what others said could not be done. Over the next 100 years, IBM developed computer hardware, middleware, software to enable organizations to process huge amounts of data. In 1956, the company demonstrated this with its first practical application of artificial intelligence, when they programmed the IBM 704 computer to not merely just play checkers, but learn from its own experience to win in checkers. IBM computers have helped put the first man on the moon. It helped recognize and transcribe human speech. It even helped defeat a grandmaster in chess. In 2011, IBM's Watson computer competed in Jeopardy! And it competed against the TV show's biggest all-time champions. Watson's AI was able to read documents quickly, find patterns in the data, and easily beat Jeopardy's all-time champions. In 2015, Watson focused its efforts on healthcare and pitched that its supercomputer would one day cure cancer. IBM partnered with some of the leading health organizations across the country to take on this audacious goal of transforming healthcare using technology. 6 years later, and over $4 billion spent on buying medical data, IBM Watson's health vertical was shut down. In January of this year, IBM sold Watson Health for cents on the dollar to a private equity firm. Despite the dramatic failure of Watson Health, it has not stopped other big tech giants and health systems, just like the University of Rochester, to try to do what IBM Watson Health was unable to do. So when I was asked to do this presentation, I asked, what would you like me to present on? And I was told, we would like you to present on the secret sauce of how the University of Rochester has become a leader in delivering technology-enabled care. We want you to do it in an opening keynote with some of the leading health organizations in New York State. No pressure, I thought to myself. Challenge accepted. So when I was working on this slide deck, to be frank, I completely discarded the deck just this weekend because I was thinking to myself, how am I going to tell the University of Rochester's story? And how are we different than what we learned with IBM Watson Health? It actually came to me of how I was going to tell this story watching a movie with my children. You know the movie, Field of Dreams, the movie with the famous quote, "If you build it, he will come." This was a movie about a farmer, Ray Kinsella, from Dryersville, Iowa, home of about 4,000 people. A movie about doing the completely illogical to achieve life fulfillment. In the movie, Ray cuts down his corn of fields at the risk of losing his family farm to build a baseball diamond. And he does it because an inner voice tells him to do it. See, everyone dreams of living a fulfilling life, and they want to do it in a place that they call home. Upstate New York is no different. This is the region of the state served by my health system. Right here is the city of Rochester. I was born and raised in Rochester and am very proud of the community that I came from. In the University of Rochester, right downtown, we have two of our major hospitals, Strong Memorial and Highland Hospital. Surrounding our two main tertiary and quaternary hospitals are dozens of towns that look just like Dryersville, Iowa. And within these towns, there are thousands of people that look just like Ray. Over the last 10 years, my health system has expanded into these rural communities. We've set up small community hospitals. We've partnered with other health system hospitals. And what we found looking at our data was that in these rural communities, there were patients with multiple medical comorbidities. And these rural communities did not have the specialty services to effectively treat them. So doing the completely illogical, we built telemedicine suites in these communities because an inner voice told us that it was the right thing to do. And this was well before the COVID pandemic, when telemedicine was cool and reimbursed. Building telemedicine suites pre-pandemic was completely illogical for a health system like mine. And I say that because my health system, like most health systems in the country, get reimbursed in a fee-for-service reimbursement landscape. We get reimbursed by bringing patients to our hospitals, keeping our emergency departments cranking out patients, keeping our inpatient units at 110% capacity, and keeping our surgeons seeing patients in person and doing expensive procedures. But despite all of this, we continue this illogical path. We set up these telemedicine suites. We purchased some of the most advanced telemedicine carts money could buy, and we invested in developing the most seamless video conferencing platform integrated right into our electronic health record. But the patients did not come to these telemedicine suites. So we thought to ourselves, maybe we needed to better monitor our patients in the communities. Maybe we needed to provide them with the right nudges to tell them, hey, we see that you're starting to decompensate. Maybe you should go to the telemedicine suite to see one of our specialists. So continuing our own illogical path, we invested in wearables, Bluetooth-enabled sensors, Bluetooth blood pressure cuffs, and we deployed these wearables through our home care service line into homes in these rural communities. And again, this was completely illogical because in my health system, our home care service line does not make money in a fee-for-service landscape. It's actually a money loser. But did our patients engage? They did not. And the increased telemedicine visits to our specialists in those telemedicine suites did not happen. Over the next several years, the University of Rochester slowly began dipping their toes into value-based reimbursement, where digital health and telehealth makes a lot more sense. Where we started dabbling our toes was in a reimbursement model called bundled payments. And we started this in our joint bundles. What this means, if you are a patient and you have a joint injury, the health system gets paid a capitated rate from that time of that injury through that surgery process until you recover. Before my health system started dipping our toes into these joint bundles, they came to my team and my analytic group and said, can you help us figure out what is the most costly part of a bundle if we were to engage in these type of risk arrangements with our insurers? We looked at our data, and what our data showed was that going to a skilled nursing facility after surgery was the most costly part of a potential joint bundle. Now, nobody wants to go to a skilled nursing facility. Nobody finds that living their life in a nursing home is the fulfillment that they're seeking for. So we thought to ourselves, well, surely technology can help keep patients out of a nursing home. Surely patients, because they don't want to go to a nursing home, are going to engage in this technology. So what we did was we invested into some of the most expensive gait analysis equipment and wearables that you could imagine. We even used cameras and used artificial intelligence and computer vision to look at every little angle of leg movements and arm movements of patients' gait, with hopes that that data, which gave us hundreds of data points, would inform us of which patients are at risk for falling and which patients are not going to recover after surgery very quickly after a joint injury. So was this data able to predict which patients were going to go into a nursing home and which patients were going to recover the best after surgery? It could not. So what were we doing wrong? What were we missing? These were the same questions asked by Ray Kinsella after he built that baseball diamond. See, when Ray initially built the baseball diamond, nobody came. And the community he lived in thought he was crazy, and the bank threatened to foreclose his home. What is captivating about the film Field of Dreams is the mystique of how blurring the past impacts the present day. It was not until Ray confronted his own past did his future change, and he then finally achieved his own fulfillment on his baseball diamond. So at Rochester, we were focused on the present, not our past. We were focused on patients' biological needs. When we rolled out those telemedicine suites, we were focused on medical comorbidities and data that we saw in our electronic health record. Data like around this patient that told us the medications the patient was taking, what their medical comorbidities were, biometric data, vital signs data, and we even added more of this biometric data into our electronic health record. But this present data was not the answer to solve our problems. In a lot of ways, this was one of the failures of IBM Watson. See, IBM invested, again, $4 billion buying electronic health record data in hopes that it would predict cancer or even cure cancer, and it could not. But this is where my health system was focused on. It was not until one of those orthopedic surgeons who was involved with our joint bundles that said, maybe we need to ask better questions of our patients. Maybe we should just ask them how they are feeling. Now, being a behavioral health provider, this hit right home for me. And I was going, of course, yes, we need to hear from our patient's own voice, how they perceive they are doing. And that's what's brilliant for us. That was game changing. So what were the right questions that we should be asking our patients? At Rochester, we are proud of our past and our history. We are the home of the biopsychosocial model. The gentleman you see here is a psychiatrist, George Engel. He was the founder and first published on this model in the Journal of Science. This is a model based on the principle that a person is more complicated than just their biological illness or disorder, that a person is multidimensional. And when they're sick, the whole suffers, not just the biological. It was the first model in medicine to introduce the idea that we should consider the patient's psychological and social dimensions when we're treating one's physical elements. So embracing our proud history of the biopsychosocial model we decided we were going to start profiling our patients, broadly asking these questions. So what we did was we focused on questions that would tell us from the patient's own voice how they were physically feeling. What was their physical functioning and pain like? What was their emotional distress levels? How were they socially functioning? It did not matter if you came into my health system for a toenail injury. We were going to ask you about your mood at that time of appointment. How did we do it? Well, about 7 years ago in the Department of Orthopedics, we developed our own patient-reported outcome data collection tool on iPads. So when you arrived to the clinic, you got handed an iPad. We leveraged a National Institute of Health initiative called PROMISE. PROMISE is this initiative where the National Institutes of Health tried taking static psychometric tools, which are 20, 30, 50 items long, and how can you use technology, computer adaptive questioning and item response theory to shrink those items down to just the right questions at the right time to ask the patient. And we started collecting on our patients the PROMISE mood instrument, PROMISE physical functioning, and social functioning, again, on every patient that hit our health system. This was collected at registration. We integrated it right back into our electronic health record. And over time, we then have now collected the largest patient-reported outcome data set in the entire country. Again, broadly and systematically collected in these broad biopsychosocial domains. Now, this is the data set that my health system uses as the foundation of all of our machine learning and artificial intelligence. So, what we have learned from our data is that our patients that live in these rural communities, and this is geo-coded data on our actual patients. The darker colors are levels of psychological distress. And what we found, the more rural you go, the more psychological levels of distress we found in our patients. And not only that, when we delved into our social functioning data, these patients were quite isolated. Significant transportation disparities, food disparities, economic disparities. Now, we know in the state of New York, we've invested heavily in broadband access across the state. We also know that about 90% of our patients use smartphones. So what a great opportunity to overcome these health disparities to reach our patients. However, looking at our own data in those telemedicine suites that we built, what we found was that 85% of our patients lived more than 10 miles away from the closest telemedicine suite that we set up. And having transportation issues, that made it very difficult to get to those suites. Now, when we looked at our primary care practices across the region, it didn't get much better, with about 70% of our patients living 5 to 10 miles away from the closest primary care practice. And again, didn't get any better for our urgent care practices, about 75% living more than 5 to 10 miles away from the closest urgent care practice. So what about those smartphones? Well, the great thing happened, we all know, a couple of years ago with the COVID pandemic. The COVID pandemic, all in itself, transformed all of our lives. And it transformed the lives of the patients my healthcare system serves. What we found was our patients, especially patients in these rural communities, engaged in telemedicine using their smartphones in their homes. But what we found was patients living in our most socially vulnerable regions did not use the video component of telemedicine. they use just the telephonic component. We did a deeper dive to understand why this was happening. What we found was, again, not a broadband issue. We knew there was broadband in these communities. The issue was the only internet access that these patients had available to them were their data plans on their phones. And we all know that when you video conference a feed to a data plan, it's going to kill your data plan. So our patients were just not engaging using video in telemedicine during the pandemic. But those who did engage with our specialists and our primary care providers via telephonic telemedicine, we found great results. We found that they had lower no-show and cancellation rates when compared to patients who didn't engage in telemedicine. We found that these patients that engaged in telemedicine didn't end up in the emergency department more often than patients who came in to see their providers in person. We found that the patients who engaged via telemedicine actually required less in-person follow-up after that appointment than the patients who came to see their providers in person. Now, insurers for years have argued against telemedicine parity. One of their arguments has always been that telemedicine, because you can't lay hands on the patient, was going to be more costly. And it was going to be more costly because healthcare providers were going to need to order expensive labs and diagnostic tests to get the data that they need to make their care plans, to actually deliver care. What our data found over the last 2.5, 3 years of the pandemic, that this was not the case. Patients who engaged in telemedicine and didn't see their patients or their providers in person required less expensive labs, less expensive imaging. Now, we're really excited that this data is actually going to be coming out in 2 days from now in the New England Journal of Medicine Catalyst. We're really excited to push this data out to show that telemedicine, when done right, is not more expensive than in-person care, and the quality of care is just as good. And it's most beneficial for patients that are safety net, that live in some of our most vulnerable rural areas. So let's talk a little bit about the remote patient monitoring and what we found with that. The first thing we found was when you have a patient in a rural area who is depressed, their likelihood that they're going to engage in a wearable technology on a consistent basis is very low. And again, we saw in our rural communities, in our underserved communities, high levels of depression and psychological distress from our data. What we also learned was all of this data from remote patient monitoring coming into our providers was overwhelming for our providers. What you see below on this graph, that is the day and the life of a University of Rochester primary care physician and how much time they spend in the electronic health record. As you can see, they wake up around 6 o'clock in the morning. The first thing they do is they turn on their electronic health record and they are in it all day long. We start to see a dip around 5 p.m. for dinner time. After dinner time, they're going back into that record again until 10, 11 o'clock at night until they fall asleep. This is day after day. And all of that continuous biometric data that was feeding in to our primary care docs and our home care providers from all of those wearables out in the community, our docs said, stop sending it to us. We don't know what to do with this data. It is not helpful for us without any context around it, without the context of where my patient is living, what health disparities they face, how is their mood, how is their psychological well-being. So we did better for our primary care providers and healthcare providers. We packaged up the data that was important to them, that PRO data, that physical functioning data, that social functioning data, that mood data. And we packaged it up in a way that it was easy to understand. Now our providers in their electronic health record can see these broad domains from the patient's own voice and how they are doing longitudinally over time. And what we have found that this data is more powerful than those biometric data collected on all those fancy sensors, all of those fancy technology that we rolled out in our ortho department for the joint bundles. And again, the RPM sensors that we rolled out in our community through our home care service line. This data now serves as our check engine light. When we see changes in a patient's mood, and we see it in relationship to the way they perceive they are physically and socially functioning, now our providers know when to intervene at the right time and hopefully in the right place. So one of the things we have done, again, leveraging this large patient-reported outcome data set, is it now serves as our foundation for machine learning. Now, at its basic, what machine learning is the computer is teaching itself to get better and better of identifying patterns in the data, identifying outliers in the data. Now, the problem that most of us in healthcare struggle with, and IBM Watson was no different, is the data we have in healthcare has a lot of noise to it. When I mean noise, it's really messy. There's a lot of variability in the electronic health record. There's a lot of data that should not be in there. Medications that we haven't reconciled yet, or old diagnoses that we have not turned off. And the problem is when you have so much variability and so much noise in the data, the computer gets confused. And when it finds patterns or outliers in the data, it may actually be meaningless from a clinical standpoint. So at Rochester, to again, get ourselves ready for the future by investing in the biopsychosocial model, by investing in collecting data systematically from the patient's own voice on those broad domains, we've been able to develop some really successful machine learning models. Now we pull in other data variables from our electronic health record, from our claims data into this foundational PRO data set based off the question we're asking, and going back to that joint bundle, how do we keep patients out of a nursing home? Because again, no one wants to live their life in fulfillment in a skilled nursing facility. We were successful. We built a machine learning model using that PRO data set. And now what we have in our electronic health record is a tool for our surgeons. So what you see on this slide is that speedometer and how that speedometer works. When a patient comes in to see one of our joint surgeons, our joint surgeons can see if I was to cut today, this is the likelihood percentage that this patient would need to go into a nursing home after I did the surgery. What we found in our data, the most predictive variables in our model that determines whether or not someone goes into a nursing home had nothing to do with those fancy gait analysis machines. It was what level of social supports does the patient have in their home pre-surgery? What is the patient's preoperative mood? So now my surgeons can be smarter about whether they cut or not cut. Our surgeons now prescribe home care services, are a little bit more thoughtful when we prescribe remote patient monitoring out via home care to the right patients, and get those social supports set up in the home before they do surgery. So they send the patient home, say, I'm going to get social support set up. I'm going to have you come back in a couple of months, and we're going to check to see how you're doing before we do the surgery or not. Now we have better outcomes for our patients because we're only cutting on those that really need to be cut. We have better outcomes for our providers doing the surgery, and we have better outcomes for our health system. This machine learning tool saved my health system lots of money as we moved into our bundled value-based risk arrangements. So the other thing of how do we meet our patients on their own journeys? Now, as I discussed, my community, like lots of communities in New York State, my patients face lots of health disparities, lots of social determinants of health that they need to overcome. In my community, transportation is the #1 disparity. And when a patient has a choice, do I use my limited transportation to go to the grocery store to buy food? Or do I use it to drive to the U of R telemedicine suite to see my doctor? They're going to go to the grocery store every single time and not go to that telemedicine suite. So what we're doing at Rochester is we're looking for new partnerships. We're looking for the ability to put our telemedicine services right into retail stores, right into those grocery stores, so we can catch the patient on their own life journey. Now, this is not a novel idea. We are seeing this happen around the entire country. We are seeing it with CVS Health in their Minute Clinics. We're seeing it with Village MD and their partnership with Walgreens. We're seeing it with Walmart and Walmart Health, and we're seeing it with Amazon and Whole Foods. Now, my health system, I am not looking at any of these new market entrants into healthcare as competitors. I am looking at them as potential partners. And we are in discussions with lots of these new retail entrants into healthcare to say, hey, we want to partner with you. We know our patients are your consumers. We know that they are going to your stores on their daily journeys. We want to help you provide better health to them in your stores. So when I think about the biggest disruptors in healthcare, and I think about the Amazons of the world, the Walmart Healths of the world, even the Best Buy Healths of the world, the biggest disruptor or potential disruptor, in my opinion, was announced in July of 2021. At that time, Dollar General came out and announced that they had hired a chief medical officer in Dr. Albert Wu. When I saw that, I said to myself, that is way more disruptive than anything Amazon can do. That is actually quite exciting because Dollar General has the opportunity to meet some of our most underserved, rural, socially vulnerable patients in their own communities. To take that even a step further, remember those geo maps that I showed you of the distance between my patients and the closest telemedicine suite, which was over 10 miles away for 85% of the patients, 5 to 10 miles away to the closest U of R primary care or urgent care center for 75% of our patients. When we geocoded the Dollar Generals in our market and geocoded all of our patients in the distance away from those Dollar Generals, 80% of our patients outside of city of Rochester live within 1 to 2 miles of a Dollar General. Now that has the potential of transformation. Now, Dollar General announced again a year ago that they are moving into healthcare. We haven't really heard a whole lot since. They just announced about a month ago their advisors to their board of their healthcare vertical. I am hoping that Dollar General sees this as an opportunity to do good and to really transform healthcare for our most vulnerably underserved. If any of you know Dr. Albert Wu, please let him know that University of Rochester would love to partner with Dollar General to transform care. So the next thing we're doing beyond those retail stores, again, knowing that our patients have cell phones, And although they can't engage in using those cell phones in video conferencing because of their data plans, we are looking at how can we meet patients in their own communities using that technology without hurting their data plan. We know that this is going to require lots of different modalities to do it. And one of the first things that my health system has done is it partnered with an external company to essentially create a power strip. This is a power strip that plugs into our electronic health record. Through this power strip, providers in my health system can prescribe things right out of the electronic health record to patients' phones, like digital care pathways to our patients, like digital education directly to the patient's phone, mobile apps, even mobile apps that we've built in-house, like our own cognitive behavioral therapy mobile app, to be prescribed by our primary care providers in these rural communities to patients' own phones right out of the electronic health record. To even things like prescribing rideshare for our patients who have transportation disparities to get to in-person services that they otherwise had difficulty getting to. And we even have prescribed out our own natural language processing chatbot that serves as a virtual patient care assistant on patient's own phone using SMS text messaging. This chatbot can help patients answer frequently asked questions, answer questions like, how do I pay my bill? How do I sign up for the patient portal? And how do I even schedule an appointment with my providers right online with my own device? So essentially creating our own digital front door to patients' own phones. Where we're going in the future is thinking beyond cell phone technology. I had the opportunity about 4 years ago to speak at a conference that Mark Zuckerberg, the CEO and founder of Meta, was speaking at. And Mark Zuckerberg was talking about just the future of technology and where he sees the industry going. Mark said he sees the future going in two directions. One direction is speech recognition, where we've seen a lot of companies like Amazon invest in Alexa, in Google Home, and Microsoft in Cortana, and Apple and Siri. And we've seen a lot of these speech recognition technologies already being tested in the healthcare setting. The other direction that Mark Zuckerberg sees the future of technology is going is virtual reality. And Meta, doubling down on this, purchased the largest VR company in the world at the time, Oculus. Following that lead, we are investing heavily at the University of Rochester. We are looking at VR technologies as being the future of telehealth, where we can meet our patients in more immersive realities. We've developed our own VR technologies, and we've leveraged our engineers at our university to even develop our own patents in VR. We now can collect vital signs, heart rate, respiration rate, directly out of that headset, just using the sensors already built in. Imagine what we can now do with that in the future. We could be providing mindfulness and meditation and cognitive behavioral therapy into patients' homes, provide biofeedback using that biometric data in a way to treat psychiatric and psychological comorbidities. We're very excited to have launched our own mindfulness, meditation, and CBT VR applications throughout our health system. And we actually have several live and in the hospital today. We are doing VR in dentistry with hopes of lowering sedative medication use. We've deployed VR in our children's hospital in hopes of teaching children new ways of coping with stress, and also to hope to reduce sedative medications. Now we know, in our hospital, there are some kids that are unable to tolerate some things as simple as getting a blood draw, some things as simple as getting a shot. And in the past, in order to manage those kids, we've had to put them under general anesthesia to get a blood draw. Now, that is not good for the kid. That's not good for our providers. That is not good for our health system. We have had great results from deploying virtual reality technologies to our kids to reduce these sedative meds. What I'd like to show you here is actually one of our children in our children's hospital using the VR application that we built. What you see is a very simple application of an aquarium. And our kids can just blow into the microphone in the VR headset and actually blow bubbles at the fish, and the fish will swim away. And we teach our kids deep breathing exercises through blowing these bubbles in this aquarium. And I'm going to show you here in a second the impact that it's had in our hospital.
Even though he is wiggling around a lot, he is still very interested in what is going on in the video. And he's not hitting, he's not, as you see, he's tapping it, but usually he'd be trying to bite and smack everyone else. Are we all done? Or do you want more? Do you want more? Okay, put it back on.
Thank you.
And it's very easy for him, usually with his grasping, it's hard to use anything. So with the cushion, it's very textural, easy on his face. And like I said, he usually is trying to go after whoever's trying to do any sort of procedure on him.
Yeah.
So he's more into this than what's going on with his body.
It's very interesting. Thank you.
You're welcome.
So getting back to the original question when I was asked to do today's presentation of what's Rochester's secret sauce to success and how are we going to be different than the lessons learned from IBM as they were trying to tackle that holy grail of using data to predict the future, to match the right patient to the right provider at the right time. For us, what we learned was just by building or deploying technology, it didn't lead to people coming or even engaging in care. For us, the secret sauce to success has been asking the right questions of our patients. We found that better questions leads to better data, which leads to better insights. We are no longer making illogical decisions based off of limited present-day data. We're embracing our rich history of the biopsychosocial model to allow us to successfully support rural communities to achieve their own life fulfillment in those communities. We've coined this term of becoming Rochester smart. And with that, I'm going to stop my share, and I think we've got about 10 minutes left for questions.
Thank you so much, Dr. Hasselberg. That was a really awesome and engaging presentation. We have one question so far in the chat, and as a reminder to our participants, if you have any questions for Dr. Hasselberg, feel free to pop them in the chat or even unmute and ask, but I'll go ahead and start with our first question. What has been the provider response to the new data approach at Rochester?
That's a great question. You know, it's taken us a lot of years to change our data culture. Initially, when we started collecting things like emotional distress on a patient that was coming in for a toenail injury, our providers said, "Why are we asking these questions? What am I going to do with this data?" And over time, as we started building that large data set and we started having some successes at a population health level and successes as we moved into value-based reimbursements, our providers have seen the benefits of collecting things like psychological functioning, social determinants of health data on our patients, and now are using that data to actually make decisions as they're delivering care. But initially, you know, like most things, change is hard, and This was a change that required us years of education and building that culture that we're going to be a data-driven organization.
Thank you. We had another comment. I think this is when you had the immersive technology slides up saying really exciting to think about how all of this is changing our healthcare system. I agree. And then the next question is interesting to hear that Dollar General is jumping into telehealth. Do you know if this will expand nationwide?
We don't know. You know, I've actually had the opportunity, you know, after Dollar General announced that Dr. Albert Wu was going to be their CMO, I quickly tried to find the contact for Dr. Wu, and I've actually had a couple of meetings with him. It's unclear what Dollar General's strategy is going to be. I think they're still figuring it out. But what we do know is Dollar General has the largest brick and mortar presence of any retailer in the United States. Dollar General has also taken a business model that is very different than Walmart and Targets of the world. Dollar General only opens up stores in communities of less than 10,000 people. And a lot of times Walmart won't even go into those communities. It's too small. So they've got the penetration to really meet our patients, our most vulnerable patients in their own communities. I can tell you what I do know is Dr. Wu seems very motivated to help transform healthcare. And I also know that their 4 healthcare advisors that they announced last month are leaders in healthcare transformation. And so I'm optimistic that Dollar General will leverage their market share to really do good for some of our most vulnerable patients. So I think only time will tell. But again, to me, you know, they're more exciting of the potential of transforming healthcare than the Amazons of the world.
Thank you. I don't see anything else in the chat right now. I'll give everyone another moment or two if you have any questions. Oh, here comes one. As you said, change is difficult. How do you get the providers to be more engaged with these changes when all they see is administration asking them to click another box, and this is not a benefit to the care they are providing, in their opinion?
Yeah, that's a great question. So at Rochester, we have a pretty nimble IT executive leadership team. So my partners are our chief medical informatics officer and our chief nursing informatics officer. And underneath our CMIO and our CNIO are multiple frontline clinicians who also have a technology data background. And we really leverage those frontline clinicians to be our champions, essentially, and to get buy-in and help inform us as we're developing or deploying new technologies or trying to collect new data. How do we do it in a way that is less burdensome? Now, some of the things I'm excited about from kind of a workforce side of things and where technology is going, when we think about machine learning in healthcare, you know, one type of machine learning that has probably been the most successful is something called computer vision. And it's essentially looking at images or looking at video. And this is what's exciting about this technology and why it's been more successful than something, let's say, natural language processing that's looking at subjective narrative data in the chart where there's a lot of variability, is videos and image tend to have standards to them. And there's a lot of new work happening in computer vision where we can put sensors and cameras in our hospitals, in our clinics, and these sensors and cameras can pick up what's happening in the room and actually do that documentation and put it right into our electronic health record. So for example, in the OR, when before a patient gets rolled in, the nurse is documenting when did the surgeon wash their hands and when did everyone else wash their hands. What a waste of a nurse that is well below his or her highest scope of practice. A computer and a camera can pick up when someone is washing their hands and can document that directly into the record for you. A computer or camera can pick up when did the patient roll into the room? When was the first cut done? So all of those things that typically we required our clinical staff to actually document in the record, the future, there's an opportunity that we can have computers take off that low-hanging fruit from our clinicians and actually make their lives easier.
Thank you. And then regarding what we were talking about with the Dollar Generals, Amazons of the world getting into the telehealth space, Ray is wondering if you know who would regulate those entities and how they're sort of tackling telehealth.
Well, I think, we're going to see the same regulators that we as health systems are under are going to be enforcing regulations, and we're starting to kind of see that with Amazon. I think it's a great example. I mean, Amazon Care, for example. Over the last 6 months to a year, there was some whistleblowing that maybe they weren't doing telehealth up to the standards that the rest of us were as a health system. That's really hard to stay on top of all the regs and licensures from different states. So what did Amazon do? Instead of continuing to invest in building out their own essentially telehealth service line, they acquired One Medical, which had already figured out the regs, had already had some success. They shut down Amazon Care, and they're reshifting their resources over into One Medical. Again, and part of that rationale from my perspective was because of regulations and Amazon Care having some struggles. So, I think you're going to continue to see that, but the same regulators that we as health systems have to report to, this is going to be the same level of rigor for the Amazons, Walmarts, CVS Healths of the world.
Thank you. I don't see any additional questions in the chat. We do have about 2 minutes left before the top of the hour. I was wondering if, a couple of comments coming in. These are wonderful cutting edge strategies. Thank you for sharing. It's all very exciting. And then one from Katie, Dollar General would influence health considerably if they added fruits and veggies at their stores. That is a great point as well.
That is something that they are talking about doing. They've rolled it out, in my understanding, about 1,000 stores in the country, partnering with local food markets, healthy, and they're going to expand it. So that's one of the strategies that they have said they're going to do.
That's awesome to hear. I was wondering in the last minute if you could give another quick plug about your articles, the journal articles that are coming out in the New England Journal of Medicine.
Oh, thank you, Nancy. Yes, very exciting. On Wednesday, we actually, the University of Rochester has 2 telehealth articles being published in the Catalyst version of the New England Journal of Medicine. Our first, it actually looked at busting all of the myths that payers have used over the years to not reimburse telemedicine at parity. So we looked at a very large data set to essentially counter every single excuse payers have used in the past to not pay. And our understanding that is the first research telemedicine article to actually do that. The second is an article about a telehealth model that the University of Rochester developed to provide behavioral health care into nursing homes across the state of New York, which has substantially scaled over the years and is now supported directly by our state's Medicaid program through the Office of Mental Health and soon the Department of Health. So that will also be coming out in that New England Journal of Medicine Catalyst. And I would like to put a plug, if we love to partner at the University of Rochester, so folks, please feel free to reach out to me on LinkedIn or via email. we love to try to transform healthcare, and the only way we're going to be able to do it is partnering with other organizations in the country. And so any New Yorkers, organizations here that would love to partner, please reach out. We would love to explore that with you.
Thank you again, Dr. Hasselberg. This was such an awesome presentation, really exciting, and I think our participants would agree with that. So with that, I will say that I will share both journal articles when they are released with all of the participants, and I'll include Dr. Hasselberg's contact information as well if you are interested in reaching out. I want to thank you again for joining this session of our conference, and I hope to see you at our next session at 1 p.m. And again, throughout the week, we have quite a few additional presentations coming up. So thank you again, Dr. Hasselberg, and everyone for joining.
Bye now.
Bye-bye.